Next patient is from Medicine 4. Akash will be presenting, and the title is The Cocktail.
Good morning, everyone. My topic is the cocktail. I am presenting on behalf of Medicine 4. And this is regarding a 44 years old Mr. Haji, who is a coolie from Kadpadi. He came with chief complaints of drowsiness and decreased response since today morning. And also had got a history of chronic cough for the past 3 months and weight loss of around 20 kgs for the past 3 months. So history of presenting illness, Mr. Haji Basha was apparently normal since today early morning. He was noticed by his wife by around 3 a.m. He was not sleeping and was found to be drowsy and less responsive, followed by which he was brought to CMC for further management. On arrival to ED, his vitals were stable, but his sugars were reported to be low. So followed by which was corrected, and his sensorium improved followed by that. But he also had a history of chronic cough for the past 3 months, just initially dry and later become productive with sputum. Also had a history of weight loss for the past 3 months of around 20 kgs. He also used to have low grade fever intermittently, but currently during admission, he had no recent history of fever or fever at presentation. Also denied any shortness of breath, no other positive histories. And past history is a known case of uncontrolled type 2 diabetes mellitus for the past 8 years. He is on OADs as well as on insulin, and he is non-compliant to his medications. He also had a history of back pain for which MRI has been done outside, which is suggestive of lumbar spondylosis. He also had a past history of deliberate self-harm. And personal history-wise, he is not an alcoholic, but he's a chronic smoker for the past 20 years. He used to smoke 10 BDs per day. On general examination, he was conscious, oriented, afebrile, but he looks emaciated. Mild pallor was present, but there was no icterus cyanosis, clubbing, pedal edema, or lymphadenopathy. On oral examination, he had oral candidiasis, and on right malleolus of his right leg, he had a partially healed ulcer. Vitals wise, he was stable. His BP was 120/80, and his pulse rate was 80 per minute, and it was regular. His respiratory rate was 16 per minute, and his JVP was not elevated. And system-wise examination, his respiratory system, he had bilateral crepitations heard over scapular, infrascapular, mammary, and infraaxillary areas. Other system examination was normal. Investigation-wise, he was anemic with normal.
What was your clinical diagnosis, Akash?
So,
clinical diagnosis. Before you go on to your laboratory investigations, what was your clinical diagnosis you made at the bedside?
It's a syndrome complex of chronic cough with weight loss, a significant weight loss.
And he had bilateral lung findings. No, crepitations over there. Did he have clubbing, digital clubbing?
No, sir. Investigation wise, he is anemic with the MCU of 80.
In the background of poorly controlled diabetes, now we had a hypoglycemic episode and also some psychotic illness with history of deliberate self-harm in the past.
And total counts at 13,400 with the platelets of 8,46,000. HbA1c was 11.6 with UPUC of 2.13. His BBS screen came negative. Also got hypoalbuminemia with total albumin was 2.3. And had also got low iron and low TIBC, and his CRP was elevated. So differentials considered in the background of uncontrolled type 2 diabetes mellitus with chronic cough and significant weight loss. Initially thought of infective pulmonary tuberculosis, COPD, chronic bronchitis, pulmonary melioidosis, also autoimmune causes like granulomatosis with polyangiitis, and malignant causes like bronchogenic carcinoma, and less likely chronic heart failure was also kept into differentials. This was his imaging of the chest X-ray, showed bilateral opacities.
What kind of opacities? Joseph, what kind of opacity? Tony?
Multiple median
Miliary, they are nodular opacities, diffuse. Miliary should be the size of millet seeds. So this is bigger than a millet seed. Some of them are actually fluffy, like Joseph said, not just nodular. So basically, are they alveolar or are they interstitial? Alveolar is nodular, fluffy, while interstitial is reticular and nodular.
Sputum export was then followed by which detected mycobacterium tuberculosis, which was rifampicin susceptible, and MGIT came 1 plus positive. So he was started on standard anti-tubercular therapy in view of drug susceptible pulmonary tuberculosis in the regimen of 2 HRZT and 4 HR. The intensive phase of rifampicin, isoniazid with pyridoxine, pyrazinamide, and ethambutol, and also followed by continuation phase was planned with rifampicin and isoniazid. During his hospitalization, his sugars were also controlled with insulin therapy. But after starting ETT, after 2 days, he started to get unexplained high-grade fever with no chills and rigors. In view of that, counts were repeated and adequate blood cultures were sent. Search for the source of foci revealed he had got a tender swelling for his right ankle and foot, right ankle joint and foot with restriction of movements, followed by which X-ray and ultrasound imaging was done, which was discussed with the radiology team. They suggested the features of probable osteomyelitis with very minimal fluid, but since it is an early stage for definitive diagnosis, they had suggested an MRI. So at this point, meanwhile, his blood cultures also grew Burkholderia pseudomyelite positive, and which was ceftazidime susceptible. So he was treated for co-infection with melioidosis as well as pulmonary TB. Was started on intensive phase of intravenous ceftazidime, 2 grams for 6 weeks, followed by eradication phase was planned with oral antibiotics. So followed by significantly improved, his febrile episode started to come down. His swelling also started to decrease gradually. He was endorsed under Dodd's clinic and he was discharged. So final diagnosis. So Mr. Haji Basha, who initially presented with hypoglycemic episode, was diagnosed to have rifampicin sensitive pulmonary TB with Burkholderia pseudomyelite positive in his blood culture, probable Burkholderia associated osteomyelitis, the background of uncontrolled type 2 diabetes mellitus with complications. So melioidosis and tuberculosis. Initially, melioidosis is an infectious disease. It is associated with high mortality as well as morbidity. It's a facultative intracellular gram-negative bacterium. So endemic regions, usually it is Southeast Asia, which includes India, China, and Northern Australia. So infection usually occurs through 3 eyes. It is either inhalation, ingestion, or inoculation. And risk factors, most probable risk factors considered were uncontrolled type 2 diabetes mellitus, hazardous alcohol use, chronic kidney disease, and chronic lung disease. In our patient, the risk factor was, we thought of the risk factor considered was uncontrolled type 2 diabetes mellitus. And in this thing, India was one of the endemic region also. And there were less reported cases of pulmonary tuberculosis and melioidosis co-infection. Especially uncontrolled diabetes mellitus was one of the major risk factor for both melioidosis and tuberculosis. Most of the reported cases during the last decade, mostly it is from the West Pacific region, which is South Asia, Malaysia, Singapore, India, and it is most often found with males. And this is regarding a case report which is seen in Brunei Darussalam. This is seen, it is near Malaysia. This is regarding a 64-year male who presented with symptoms and radiological features of pulmonary TB, but his sputum culture also yielded a Burkholderia pseudomyelite, who were treated for both TB and pulmonary melioidosis. Also, this is another case report which was regarding a 64-year-old male who had got left-sided abdominal pain. So he had pulmonary and gastrointestinal involvement of TB, and he had also got splenic abscess which grow which grow melioid. So this was some of the recent reported cases of co-infection with tuberculosis and melioidosis. So it's usually found around Malaysia, India, and most of the co-infection it is occurring with males, and risk factors considered it is most probably diabetes and alcohol. And this is Darwin's treatment guidelines for melioidosis. In our patient, we had we suspected it could be probable Burkholderia associated osteomyelitis. So he was sent off with, we planned for an intensive treatment for 6 weeks, followed by eradication phase of 180 days. So take home points in our setting. patients diagnosed with tuberculosis or routinely screened for diabetes mellitus, or the level of control of diabetes mellitus is assessed. But however, we do not routinely screen patients with diabetes mellitus for pulmonary tuberculosis unless they have symptoms or findings that are suggestive of tuberculosis. Co-infection is usually rare, but in endemic areas like India, people diagnosed with pulmonary tuberculosis, especially with the background of uncontrolled type 2 diabetes mellitus, keep an eye out for melioidosis also. Thank you.
Thank you, Akash. Treatment is going to be a challenge. This gentleman is long-standing diabetes, background psychiatric illness, already non-adherent to therapy, and now we have two diseases which need long-term antibiotic therapy. It's going to be really challenging. Can you please go back to that slide on your plan to treatment of tuberculosis? So, for our postgraduates here, no postgraduates. Okay, Tony. Do you agree with this treatment regimen for this particular gentleman? Yes, no, or? Pardon me? So we know he has, you saw the X-ray, you saw the expert result, CBNAT result. Shreya? So what has happened to recommendations from WHO, from National TB program, treatment of tuberculosis from standardized regimen, it has become personalized. Okay? And the guidelines recommend three things which tailored according to drug susceptibility, rapid molecular test confirmed by phenotypic drug susceptibility testing. So this is rifampin susceptible tuberculosis. Akash has mentioned that there. Second is weight, body weight. And it's a daily therapy, no more independent therapy. This gentleman has one more additional thing which will tailor the drugs or duration or both. David? Diabetes mellitus. So what is diabetes mellitus due to natural history of tuberculosis? Number one, he mentioned that no, increases the risk of developing tuberculosis. Second, risk of recurrent tuberculosis is substantially higher, especially poorly controlled diabetes. If they have cavity and at the end of the intensive phase, you remain culture positive. So did he have a cavity on his X-ray? So don't say that it's only 6-month therapy. So if he has a big cavity, is that a cavity in the right midzone? Or I'm imagining. If there's a cavity and the patient remains culture positive at the end of intensive phase, you have to extend the maintenance phase to 7 months, 9-month duration. Has he come back for follow-up?
No, sir, not yet.
Not yet. Is he coming back to us for follow-up?
Yes, sir.
Or
Yes,
going to his?
Yes, sir. He coming back to
So
us.
he's come to follow up in OPD and his osteomyelitis is worsened than the leg. So he advised for admission. He is coming.
Is he taking his drugs, anti-diabetic drugs, antibiotics, anti-tuberculosis therapy, or is?
His diabetic therapy he is not very compliant with. He advised for admission.
So his background makes him non-adherent to diabetic therapy. Therefore, he developed both TB and melioidosis. Very sad. Very unstable social situation. No, he's the earning member.
Yes,
Yes, sir. Psychiatric illness, but he's not working at the moment.
He used to be working, sir, before, but for the past 3 or 4 months, he is at home only.
Any other questions or comments? Yes, Amit.
For you to clear. But was the culture report available? Not yet.
Sorry, sir.
Culture report for the
Midget is not still pending.
Nice.
So why did you already decide that for validation phase we are going to use only drug therapy and not add the term?
Yeah, good point.
Because earlier, if you remember, it was just when we used to do everything, it used to be HRZD plus HRE, right? Then they said HR is enough, provided isoniazid monoresistance is ruled out, which means that if we have a midget culture that shows that it is susceptible to isoniazid, you don't have to use ethambutol. 2 good drugs are enough, H and R. But if you don't have a culture, I'm not sure if you can.
No, absolutely correct. You should follow up and make sure that he is pan susceptible M tuberculosis before you decide on the drugs in the maintenance phase. Absolutely correct. Thank you.
Sir, and two more points. One is Dr. Radhadi Mohan for our math, he said if you have an expert showing rifampicin resistance is not detected.
It is not.
Rifampicin resistance is not detected. Detected is rifampicin resistance not detected, not rifampicin susceptible, because you don't have a culture showing that rifampicin is killing the organism. You are not detecting the rifampicin resistance.
Semantics.
Yeah. Second is regarding melioidosis.
See, in future, in the next few years, you are going to see molecular tests as the gold standard for susceptibility testing in M tuberculosis. We are going to see whole genome sequencing, pyrosequencing, and all this. But as of today, phenotypic drug susceptibility testing is the gold standard. And then, virtually every patient who is rifampin resistant on phenotypic testing have mutations detected by the molecular testing. So, yeah, the correct term is that rifampin resistance not detected. You cannot say rifampin susceptible based on a molecular testing. But yeah, conceptually you're right. Me, that's just semantics.
Until we find another mutation that causes
Yeah.
Other point is actually with regard to medicine one's presentation as well, because with empiric therapy for melioidosis, I presume that that particular line that she took was probably from a literature from southern China or Vietnam or somewhere like that, where melioidosis is endemic. And in fact, the empiric treatment guidelines for acute community, and they say much more acute disseminated melioidosis than chronic anaphylaxis form. Melioidosis is in fact the most common etiological agent of community-acquired pneumonia sepsis in many such regions. So I recently stumbled upon the antibiotic guidelines from Vietnam, and they actually didn't have empiric ceftazidime for patients who come with acute community-acquired pneumonia requiring hospitalization or are septic. So that particular point might have been, so it is always important to see what is the source of this thing you're saying. Of course.
So knowledge of the local epidemiology. Okay, thank you. Any other comments? Okay, we're beyond time. Thank you very much. All patients present, all the 5 patients, doctors something unique. But my request is that number one, your presentation should stick within time. Today we exceeded time. I take the blame for that. So make sure that your presentations are 8 minutes presentation and 4 minutes for discussion. So don't have 40 or 50 slides. And please order your thought process from history and physical to formulating a list of differential diagnosis, most probable to the least probable, then the supporting investigations. Okay. So let's make clinical reasoning, learning of clinical reasoning skills, the most important task of clinical meeting. And let's, the new year, let's resolve that we will less often stumble on a diagnosis and actively seek out diagnosis. Thank you. And thanks to all the presenters and the faculty who supervised them. Thank you. Oh, okay. First presentation. Okay. Wow. Okay, David.